can actually paralyze your ability to provide the best care possible. If you feel that your sad feelings for a patient situation is getting in the way of your providing them with the best care possible, please talk to your supervisor about that. From my experience, at one point I worked in a hospital. A patient came in who was just about my age, in her late 30s, and she had two daughters that were approximately the same age as my daughters. She had been having a lot of abdominal pain, but had not come into the hospital or sought any medical advice because she did not have insurance. But instead, a neighbor was willing to give her some of her pain pills that she hadn't used. Until the pain got so excruciating, she had no choice but to seek medical attention. By the time she got to the hospital, surgery was performed, and she had a cancer that had spread everywhere. And they were only giving her a few weeks to live. I was so sad about that situation because I was putting myself into her position, having daughters the same age, worrying about their future, and I needed to talk to the head nurse of the unit and ask that I not be assigned to take care of that patient any longer, because the care that I would provide for her was not the best quality of care that she deserved. Accepting the patient as a person worthy of dignity is basic in providing care. Acceptance means working with patients, even those who may display some undesirable behaviors, and you need to do that without rejecting them. Acceptance also means caring for individuals whose value system may differ greatly from your own. Think of some behaviors that you find objectionable. It might be someone who's a smoker, it might be someone who's extremely obese, maybe homosexuality is difficult for you, someone who has had an abortion, excessive use of alcohol. Those things might be areas that you struggle with. Even when patients engage in behavior that you think is wrong, bad, or immoral, they still have a legal and ethical right to have high-quality care provided. Sometimes gaining some knowledge about a person with a behavior that might have been objectionable to you can help change your perception. I worked with a fellow, and over the course of time that I worked with him, we became better and better friends. He was extremely good at what he did. He was very caring to the students that he worked with, and he had a wonderful sense of humor and commitment to his job. And as we became closer, he shared with me that he was a homosexual. Well, I had had very limited knowledge about homosexuals in my past, but the little I thought I knew, I didn't know that I liked. Getting to know this individual helped me a great deal because he was able to help dispel some myths and some misconceptions that I'd had about homosexuality, and as a result changed my perception about him as an individual and about homosexuality in its entirety. There will be times when you experience anger, frustration, or hurt because of a patient's behavior or the comments that they may make. Coping with your feelings in an acceptable way is really essential. Some acceptable ways for you to cope with them might be to just leave the room. Of course, before you do that, you want to make sure that the patient was in a safe situation, that they had a call light with them. But sometimes just leaving the room, having a chance to cool down a little bit, and going back in later, or having someone go back in your place can help in helping you cope. Another way would be to discuss these feelings that you're having with your supervisor. Many times the supervisor has had this experience in the past and may have some helpful tips for you. Engage in physical activities. Our jobs are stressful. many times physical activity can help diffuse some of that stress. Unacceptable ways of coping include yelling at the patient or another caregiver, threatening them, demeaning them, or slamming doors. Those or any other negative ways are unacceptable. Determining the reason that a person behaves in a certain way can help us know how better to help. One time, a patient was putting their light on incessantly, and you will find that there may be patients like that, that you'll just get done providing them with something, you'll leave the room, and the light's back on again. Well, after that happens numerous times, that gets rather annoying. And so I thought, you know, I better sit down and talk to this person and find out what's going on. In the course of the conversation, I found out that this individual was really frightened that she was going to die. And she was very afraid that she was going to be alone when that happened. And for her, she thought the best way that she could assure that she wasn't going to be alone is to put the call light on repeatedly and make sure that someone was there in her room most of the time. Well, knowing that, I was able to come up with some strategies for her to have a sense of not being alone, at the same time not continuing the practice that was irritating to not only myself but other caregivers. We all have a personal space, a private zone. Sometimes people call it a bubble that's around us, that we believe is an extension of ourselves and belongs to us. We carry this space with us at all times wherever we go, except for a very select number of other persons whom we allow to enter that space. Could be your children or a spouse. We tend to be uncomfortable if others enter that space. Remember how it feels if you get on an elevator with a bunch of strangers and you need to be closer to these strangers than you really feel comfortable with? That's an example of how our personal space might be violated. The size of this space appears to be partially determined by culture and can vary considerably. In some cultures, in Mideastern culture and Russian cultures, it's not unusual a greeting of strangers, particularly for men, to be kissed on either cheek. That's something that our Western culture doesn't embrace. Although individuals vary in their need for space, in our Western culture, most persons maintain similar distances from each other according to their relationship and the activities that are being undertaken. For example, two men that are strangers on opposing teams might grapple with each other on a football team, on a football field, when they would never think of doing that at the end of the game in a locker room. The accepted level of personal space in our culture depends on the situation. It ranges from a very intimate space of less than a foot to a personal space that would be a close friend, to a social space, which would be casual acquaintances, and then the farthest distance would be a public space, which is usually greater than about 12 feet. In our culture, if one person feels that a second person is coming too close, the first person tends to back away to maintain that desired distance between the two. In fact, backing away shouldn't really be necessary, and any subtle movement of the body in a backward motion should signal to you to stop, that you're getting too close to their personal space or their bubble that is around them. Consider this when you approach a patient in a bed or a wheelchair. Remember that their confinement prevents them from backing away from you. Be aware of subtle movements, such as moving the head, tucking the chin, tensing muscles, or avoiding eye contact that indicate discomfort